Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the program. This is Aebhric OKelly. This week, we are recording from Kilimanjaro Christian Medical Center here in northern Tanzania. And I am joined into our studio by three current BSc Remote Paramedic students who are here on clinical placements. Lads, tell us a bit about yourself and what's keeping you busy.
So my name's Finn. I'm at the end of my first year of the BSc. I have a history of teaching. I teach English in Malta, it's my home. I've been in KCMC for about 6.5 weeks now.
Hi, I'm Pietro. I used to be a geologist before deciding it was too boring and then deciding joining the college. Now, in my third year, done with my exams and then just finishing up my placement. Been here 8 days. Maybe a bit more.
Hey, I'm Grant. I'm from Birmingham. My current background is ambulance technician, pre-hospital care, about 14 years experience. I'm currently a BSc Year 3 student with CORUM, and I'm currently in Tanzania at the moment on clinical placement on my last one before I graduate.
So one thing that I really like about the college is the diversity and the various varied backgrounds. So we have someone from Malta, we have someone from Great Britain, and we have someone from Italy. But it's so good for me to see where my students are, so we put all this into motion. I've been pushing for this for 10 years now, and these three are here hitting the ground running, being able to do what I've never been able to do, which is spend 6 weeks in Tanzania. So what I want to know and what our listeners want to know is your experience here at KCMC. So, Pietro.
Well, what to say? I had obviously no previous clinical experience of any sort. I used to work for the Red Cross, but not in clinical roles. So it was maybe a bit hard in the beginning, my first placement. But I was with Grant, was already had quite an extensive experience. That was really helpful. But I got to learn quite a lot, and now I'm quite much more confident and doing pretty much everything I should be doing or should know how to do.
Finn here. This is my first real emergency experience. I've had clinical placements in non-emergency settings at home. It has definitely been interesting. It's very, very different to what I'm used to, especially my regular day job as a teacher. But I definitely hit the ground running. I landed at Kilimanjaro Airport at I think about 8 in the morning, and I was in the clinic by 11:30. And the amount of freedom you get after the first week, 2 weeks, the doctors get to know you to carry out the skills you've learnt. It's incredible.
Hey, it's Grant again. So my clinical experience from an ambulance service background to obviously coming into a hospital on placement is completely different to austere or critical care. With all the obviously different policies and procedures in place. The doctors are there to obviously lead you, and the nurses are, there to engage with you and obviously to protect you. But meeting Pietro back in March was my first time here in Tanzania, and we're here again now. So yeah, it's going good.
So what I've noticed in KCMC here in the EMD is there's a difference between what I see the medical students, the expat medical students doing, and what I see my quorum students doing. I am obviously biased, so that evidence is not admissible. So if I can get the three of ye to just have a comment on your experience with your interaction within the team and the other expats, and how is that different, or what is quorum doing well, or what is quorum not doing well when it comes to that interaction and experience?
So Finn here. I think something we do quite well is we integrate with the staff a lot better. So we know most, or if not all, of the nurses on first name basis, and the doctors as well. We'll go for dinner with the doctors and the nurses, so we form quite a good relationship with them, and that results in us being trusted to do more complex procedures under supervision, and then the basic procedures on our own, which I find quite nice compared to the medical elective students who they just don't form these connections.
Yeah, it's Pietro. That was like Finn was saying. Usually, maybe it's also for demographic, like what most of the students are here from. The older students usually stay by themselves, but like as we're just the three of us now, have much more of a relationship with the people working at the EMD, nurses and doctors. And yeah, we go out with them, we have dinner, have drinks with them, and that reflects as being much more trusted. And yeah, and we also show up every day.
Hey, it's Grant. The difference, obviously, with us is we don't just show up for like 2 hours, 3 hours at a time. We do 12 hours, 14 hours. We are a 375 hours placement, each placement, in order to achieve our goal, which is to qualify. We obviously integrate with the staff. We're a team. We're here as a team and we work well as a team. And we're obviously dealing with life-saving treatment here and obviously dealing with people, and lives matter. And obviously, this is going to change our career.
I just want to hop on back to something. So back onto what Grant was saying, and what I was saying about like relationships and doing these life-saving procedures and having difficulties. Obviously, none of us who come here can speak Swahili. It's not a language I've ever thought of before actually coming here. Having this relationship with the nurses and the doctors, being able to have them translate in the moment for us, it's a lot better than using something like Google Translate or speaking to patients who just can't speak in English like some of the other students do. It really makes things a lot easier for us in our practice.
So, lads, I would like very much to hear your experiences on the EMD, on the A&E department, the emergency room, as the Yanks call it. So what's it like? How many patients are you seeing in a shift? And what kind of interesting injuries and ailments are you on about?
So Finn here. It really varies day by day. Some days it is absolutely dead, no pun intended. Other days it is absolute chaos. We've had days where, I don't know, we get maybe 5 patients in 12 hours. Other days where we've had at least 100 in 12 hours. Works the same with the shifts as well. You get in maybe 8 o'clock up until 2, there's absolutely nothing to do. And then as soon as it turns 2, a bus comes in, loads of people, but I'll let someone else talk about those cases.
Yeah, Pietro here. We get to do not quite a lot, improvised things. Like it's obviously different to our like European hospital, but there are quite a few interesting things, like improvisation wise. Like a very interesting one is called the TPIS. That's basically when someone gets intubated and have spontaneous breathing because they're not paralyzed. We just basically take a piece of corrugated tube, cut a hole in it, and stick it on the tube. And then one side gets like the oxygen tubing taped so they can have fresh oxygen and then breathe out the CO2. Other things are like very often the beds, like the bed head doesn't rise. So we have to stick random things under to like improve patient breathing. For tubes, we just tie them off with a piece of gauze that we roll as some sort of cordage, and we use that for pretty much everything, every kind of tube, like being ET or energy tube, OPAs too. Yeah,
it's Grant here. So what I've seen here, obviously at KCMC, is obviously improvised trauma. So people don't come in with cervical collars. They're improvised, obviously, with sheets. So we roll the sheets up and then obviously use them as head blocks. And then obviously if we suspect a pelvic fracture, we use a sheet to bind it together. And that's improvised medicine.
So, lads, I am curious to hear about some of your experiences with injuries, without mentioning any type of patient identification. But have a go and tell us about what kind of things you've seen, what sticks out as maybe a single patient for now. We'll talk about more case studies in a bit, but so tell us your experience with the type of injuries you're seeing and maybe some of the skills you guys are working on.
So I think the most common injury sets we get is TBIs. No one wears helmets out here, and they drive like lunatics. Well, I would say we get maybe 5-6 TBIs per day. No one was never fresh from the injury. They're usually 2-3 days post-injury. So we're having to manage with whatever the peripheral hospitals have done for that patient now.
Hey, so it's Grant again here. So one scenario that I've seeing well-being here is I seen a postpartum hemorrhage, which she obviously become unstable and she become unconscious and stop breathing. With the team, obviously with the team effort, she went into cardiac arrest and we got output and we got her back. But unfortunately, under the circumstances, we got her to gynecology, to theatre, and unfortunately she arrested again, and was unsuccessful.
So I'm just going to jump in here for a second. You had a ROSC from a traumatic cardiac arrest. That is fantastic. So tell us why you broke the normal ROSC rates of that. I mean, a traumatic arrest ROSC. What did you guys do?
Improvised, and obviously we jumped on it straight away. We followed the hospital's protocols and obviously given TXA and given blood, kept her stable until she became unstable. And because obviously the teamwork and, the efforts of everybody involved and the challenges obviously we're facing to get ROSC, sometimes it's not achievable, but we were successful. And this is a good scenario, KCMC placement for COROM students to face with the course.
Pietro again, going back to what we commonly see, as Finn said, we have quite a few TBIs. Some of them are sent from referrals from smaller hospitals. Some of them sometimes are fresh. But another thing we saw, at least I saw more often than last time I was here, that was in April, was more mountain sickness from people climbing Kilimanjaro. Usually not actual mountain sickness, but usually they just have pulmonary edema and not just mountain sickness. We had some of them. It's quite popular tourist destination, and climbing Kilimanjaro is quite high. They do it usually a bit too fast.
So lads, we are at the base of Mount Kilimanjaro, the highest point in Africa, and we are the main hospital, the tertiary hospital of all northern Tanzania. So I imagine that the three of ye have had some quite interesting cases on altitude problems, altitude illnesses. So have a go. Tell me, who wants to have a chat about what you've seen?
So I can bring up one specific patient. This patient came in a few weeks ago, and just jogging my memory a little bit. So they came in with quite severe confusion, not a happy bunny. We ended up sedating the patient. After we ran our monitoring, we found the SpO2 was about, 80? If I remember correctly, somewhere around 80%. So we get the patient on oxygen, and due to, up until this point, unknown, he is pulling the oxygen off, so we sedate him further. We struggled to get a good history. The guides who brought him in very, very quickly left, probably for their own liability. But we found out later that the patient had climbed Kilimanjaro in 3 days and then gone down in 1. So it was a total of a 4-day hike. There aren't many words that I can really use to describe how irresponsible that is. Not really on his part, because he's not a medical professional. He's not going to know these things. But on the guides, Pietro is saying it's on him. It's a bit of both. But yeah, he had, if I remember correctly, Hayes and Hape.
Yeah.
Yep, so Hape and Hayes. We medevaced him to Kenya, I believe.
Nairobi.
Yeah. And Grant's going to tell you a bit more about the science behind that.
Yeah, so we medevaced him from KCMC to the airport, Kilimanjaro, where air ambulance intubated, and took him to Nairobi for further treatment. As students, we actually tried to find contact for this patient, which was quite difficult. Came in very agitated, confused. He had signs of pace. He had no form of communication, no documentation. The guides knew nothing about him. He previously come from a clinic, which we obviously followed up prior to obviously the medevac going to the Kilimanjaro airport. But yeah, to obviously get Hape and Hayes and AMS, the height is about 6,000. You need to have a good duration of a good 7 days. 3 days is not not enough. These are emergencies which are coming into KCMC, which we're dealing with as co-rom students, and which is giving us an insight into osteocritical care.
Yeah, I wasn't there on that one, but I would add like that if you're able to climb it in 3 days, that means that you're probably used to, well, it's not technically climbing, it's walking, but you're quite physically fit, and you're quite used to run uphill, so you should know that it's not something extremely wise to do. But besides that, it's quite a common thing we've seen, like people climbing a bit too fast and then getting pulmonary edema from that. Yeah, and headaches, obviously, and like the whole spectrum of AMS end up with a pulmonary edema, but they're usually fine. They obviously also they take prophylaxis, like they take acetazolamide, usually as prescribed, but sometimes they still get something.
So I've only been here, was 1 week now, and I had a HAPE patient come off the mountain, and they got the heli, so they descended quite rapidly. They land right outside of our hospital. So she arrives, and she now just has a little cough, and they're a bit cross because they're, especially the dad, so that they're both Yanks. So that the husband was starting to be a bit cross of, why are we coming now? She's fine. And I had to explain to him that yes, she had HAPE. I did ultrasound on them, and they were pretty clear. I'd say three, maybe 4 of the rays that indicate fluid. But I had to go out of my way and discuss the concepts of altitude medicine. We often get someone who is somewhat poorly, someone who isn't doing well. They get on the heli, they come down to this altitude, suddenly their symptoms of AMS or minor HAPE are reduced, and they just paid $4 or $5 grand to walk the mountain, and now they're down. And it's really important that one of the lessons of altitude medicine is you always have to exit. You always have to descend if you have the symptoms. And they descended. They might have saved her life, even though when they got down, they bloody well walked out of the A&E department and they were fine. Altitude injuries are just not something you bollocks out. It's not something that you want to faff around with. You want to have a decisive descent protocol. Any other comments, lads, on some of the experiences you've had with altitude medicine?
It's grand. So as Aebhric just said, the symptoms don't just rapidly just come on. They come on later. And, these signs are quite shocking when you come into EMD and they're going for CT scans and you're finding HAPE and you're finding HACE and AMS, and having to start the pharmacology process and give you medications, obviously, to keep these people alive.
Just add a comment on the helicopter used. Is a medevac, probably not the appropriate term in that case, but from using a helicopter that doesn't have a winch, so they just carry them back on their shoulders. The guides and porters carry the ones that got injured back on the shoulder to a helipad, and the helicopter is just literally a helicopter without nothing inside, so they get no treatment there.
I think more related to what Grant was saying, not really Pietro. The vast majority of patients who come in are mild. Like Aebhric was saying, they may be a bit more severe on the mountain, but once they get down to where we are, which is maybe 800 meters altitude, they cool off. They feel a bit better. I would say we have maybe a 95% walkout rate. Like patients will almost always leave on the 2 feet. So yeah, the vast majority of our patients are recover quite quick, but it's also a broad spectrum. So I can't remember, one of us said about the fitness of the people going up. I have seen women that were maybe 5'2", maximum 45 kilos, do it, and I've seen guys British Special Forces who are like 6'4", 100 kilos, 120 kilos, and they struggled. So it really depends on your deeper physiology. That's not something we can really that anyone can really just look at you and go, yeah, you'll survive, or no, you won't. It's much deeper.
So lads, each time you guys do a clinical placement, you have a workbook written by our Bachelors of Remote Paramedic Practice faculty. And in it, you have some of the skills you have to get through in order to call yourself a bachelor's degree paramedic. So my question is, what's it like? How is it going through that checklist? Is it difficult? Are you getting through it? What kind of skills are you doing? Or what kind of skills are standing out? And most importantly, as the Dean Emeritus, I do want to hear this. How can we improve your experience?
This is Pietro. We have a workbook to complete to assess the placement. We have a list of skills like either it's independent, supervised, like not assessed. So we have like basic paramedic skills, patient assessment, history taking, airways, research, and things like that. And those are the things that we practice at the EMD besides something else, like setting up ventilators sometimes.
So Finn here. Some skills I quite enjoyed going through. Oh, well, maybe enjoy isn't the right word, but I had my first opportunity to do CPR on an actual person. You train it in first aid courses in the classroom, for years and years and years. And then actually doing it on a person was quite an interesting experience. It was a team of another quorum student and I think we went for about 10 minutes and we got ROSC. And the patient arrested again and the family decided DNR. But having that opportunity was quite interesting. I enjoyed it. Enjoyed it as much as you can, I guess. We do, like I said in the beginning, we get quite a broad range of skills we get to carry out by the doctors, by the nurses. So if it's a bit of a slow day or a bit of a busy one and you want a break, you can sit in triage and just spend 2-3 hours triaging patients, going over the very basics, the bread and butter of patient assessment. Or you can spend time in trauma doing more complex procedures. I think as third years, you two can do chest tubes. I think Pietro and Grant will tell you more about that if they can. I am not allowed to do chest tubes as a first year, but probably for the best. Something I think I've brought from this placement is an appreciation for needle safety. Not everyone here knows sharp safety properly. And it's made me aware, just how dangerous needle stick injuries can be. I think we've had a few of some of the medical elective students getting needle stick injuries. Thankfully, none of the quorum students have had, because we are very well trained and it's drilled into our heads. Sharp goes out, we yell sharps out, and sharps away.
Hey, so it's Grant here. You don't come to placement until obviously you're competent. You're trained with all these skills and given these skills by the college in 104, which is LS PALS and ITLS. And obviously you have to take a basic set of vital signs. Like Finn was saying, obviously you can do triage, and Pietro was saying you can do obviously advanced stuff. I've obviously took the opportunity to go to theatre and obviously intubate somebody and obviously follow somebody and obviously resuscitate obviously a 32-week baby.
Something Grant mentioned, not everything always goes well. Sometimes, we do our best, patient doesn't recover. I think something that we get here is we're given a lot of freedom, but also protection. So I've had one opportunity to intubate and it was quite a difficult airway, and unfortunately I tubed the stomach. But the attending doctor, the top doctor, was right behind me. So when I told him, I've not done it, he took over, got the airway sorted. So we have room to make mistakes, and I really do appreciate that. Having that first opportunity to mess up and not be shouted at or not berated. So it's important.
So lads, you guys are staying in the doctor's compound right on KCMC campus in House A1. House A1 is something that Quorum has been using for 10 years. We have paid a lot to have it upgraded, a new roof and additional upgrades and enhancements. And I want to hear your experiences on the accommodation side, and also some of the fun things you guys are on about, or if you've gone off to the waterfall, or if you've gotten schistosomiasis at the lake. Is that what it was? Somebody got schistosomiasis. Not one of us. But, so I want to hear what kind of fun things you guys are doing, and what's the crack like?
So Grant and I, we spent a bit of time in another house. I wasn't there when this originally happened, but the others will probably tell you more. There was a bit of an accident in A1 back in April. So while they were fixing us up, Grant and I were in A9, and A9 was like a water park. The pipes were always leaking. Grant's bedroom was absolutely flooded at one point. But we moved out pretty quick. I'd say a few weeks. Now we're in A1, and we've been there 2 weeks, I think. It's comfortable. The beds are definitely better, and the sofas are very, very comfortable. Yeah, I'm quite happy.
This is Pietro. Accommodation-wise, I have not much to say. Just sleep there.
Hey, it's Grant here. So accommodation-wise, so we faced a few problems, which we had to escalate to co-rom management, to John Clark and Aebhric and Alfredo. We had no hot water,
Grant just mentioned about the tile floors, and that reminded me. Almost all the houses in the compound are stone floors. They're not very nice to walk on. They have giant cracks. But A1 has tiled floors, which is incredibly fancy here. It makes cleaning the floors so much easier. It makes just walking more comfortable. I don't know how to describe it.
Hey, it's Grant again. Obviously, before you come to placement, you'll obviously be given advice about equipment to bring. So you need mosquito nets. Definitely need mosquito nets and repellent. Definitely sunscreen. Definitely anti-diarrhea tablets, obviously, just in case. You can get medication here, but obviously it's best advised you get it before you travel. But yeah, there is obviously hooks in the walls in every bedroom in the co-rom house. So it's obviously adaptable and ready for you when you arrive.
So another question I have for you lads is fun. So I know you're here to learn and you're doing that, but so what kind of things have you done to off-gas, to relax, to blow off a bit of steam? Have you gone to the waterfall, or there's a spring in the middle of the Serengeti with stone cold where the little fish that bite your toes are? It is brilliant. And it wasn't that place that the girl got schistosomiasis. I'm just saying it wasn't that one, but if you go to a lake, you're going to get schistosomiasis. But so have you gone out? Have you gone on to my favorite place, the best pub in town, which is called Killy Wonders Pub? It's rooftop, and you have a lovely view of the whole surrounding area. And if herself is cooperating, you'll see the mountain as well. So, lads, what have you done for a bit of fun?
So it's Grant here. So in terms of fun, so in March when I came with Pietro, we went with a master's student, Ben. We went to Manturi waterfalls. We went to a coffee, how they make coffee and to taste coffee. And then we ate with the locals, and we was in the orphanage. In terms of fun, there's loads of places that you can go. There's loads of places that we don't recommend. Previous past experiences of other students. There's places like Amos Bar where they play their local music. It's quite high-pitched noise at the doctor's compound. And they have pool tables, which is like 500 shillings, which is nothing. And it's like 70 cents for a beer, which is nothing. So as Aebhric said, there's enough to let off steam from the EMD and the placement hours. It's vital to obviously complete the clinical hours, but it's also good to socialise with doctors, nurses, get them involved, and obviously make friends internationally and make connections when we go back home.
Hey, Rick, I don't know where you've been, where fish eat your toes, but if you could give me the address, that'd be lovely. I went for 3 days of hiking in a part of Tanzania called Usambara. It's about, I think, 5 odd hours away. That was pretty fun. I got to see some monkeys. I got to see some chameleons. I was middle of nowhere, but yeah, I didn't see white people for like 3 days. It was pretty good. So what else do I do to let off steam? I've been to the market a few times, the secondhand market. I think it's Memorial, it's called. That's pretty decent, but it's chaotic. People will touch you, they'll grab you, they want to sell you stuff. They try and sell you lots of used clothes, especially from Europe. They'll sell you animals. They'll try and sell you wives. It is absolutely mental. But I guess if you want a wife, go to Memorial Markets.
Is that where you bought the chicken and named it Liberty?
I did not, in fact, buy a chicken, but some of our old housemates, as a birthday gag, bought one of the German students a chicken and named it Liberty. This chicken cost, if I remember correctly, about 15,000 shillings, which is about €5 maybe for a chicken, like a healthy adult chicken. So it just runs around the doctor's compound now. That does remind me, we have a cat. We have a house cat, which migrated from A9 to A1. She's called Rafiki. Beautiful white and grey pattern. But the Germans are allergic, so they don't let her in the house. Very, very unfortunate.
So, lads, my final question for you is this. What advice do you have for the new medic, the new doc, new nurse, who is just starting out on the career in austere medicine? And you can kind of extrapolate a bit on what advice do you have for someone who wants to come to KCMC?
I think the first thing on your first, second day, once you get in, once you meet some students who are already here, definitely, hopefully it still exists, but definitely ask for to be added to I think it's called the KCMC Internationals group. It's on WhatsApp. I think right now we have about 150 people on it. So whenever people want to organize, tours, or they want to go up Kilimanjaro, they need a few extra people, they'll post about it. We also have a section in the description specifically for places or companies to not go to. If they're a bit unsafe, they don't treat their workers too well. Yeah, and that is quite a multinational.
Hey, it's Grant. So, forthcoming students, so I would strongly recommend COROM BSc course, paramedic program. Strongly. And KCMC, this is my third year now. But yeah, I'd strongly recommend the BSc program.
Just again, suggestion for anyone starting his career, I don't have any. I'm just starting for it. Suggestions about KCMC and Moshi in general. Not even, I've been to Moshi like probably 5 times and haven't seen much of it.
So, lads, I appreciate you taking a bit of time this afternoon and time away from the EMD to have a chat about your experiences. And it's an honor to be sitting with the three of you. Like, you guys are hitting the ground running. You guys are doing things that I put into place almost 10 years ago. And on a personal note, you guys are doing things that I won't be able to do. You are able to have your initial training and your initial placement here. I wish I had this in the early 90s when I started out. This is a fantastic, I'm jealous. I'll be very honest. I'm jealous. And thank you for taking the torch and pushing the evidence-based medicine forward, for making your community a better place.
Pietro, thank you.
Hey, it's Grant. Thank you.
It's Finn. Thanks for the opportunity, Aebhric. It's been a pleasure.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.